Are you pregnant? Well, are you aware of the increase in medical interventions? In this video, you are going to hear from Dr. Robyn Thompson and midwife Rachel Austin as they discuss the increase in medical interventions within the hospital system. If you stay till the end, you will gain so much knowledge around the subject, but you'll also hear them answer some very helpful questions from our viewers. Now, give us a like, give us a comment, and don't forget to hit that bell to subscribe. And also, if you pop down below to the description, you'll find a downloadable link to Dr. Robyn's free guide towards pain-free breastfeeding. We hope that's helpful for you. Here are the very wonderful women themselves sharing their expertise with you.
Hey everyone, and welcome to Dr. Robyn Thompson, the Thompson Method Facebook page. And today we are on Tuesday, the 3rd of August, which is right in the middle of World Breastfeeding Week 2021. And today's topic of conversation, before we get to the conversation, let me introduce, we have Dr. Robyn in the top left. So we're over there. We have Rachel Austin up here. We have Sarah over there, Sarah Jackson. And the topic of conversation, I feel like
we have Marie Wilson.
Marie Wilson.
Yeah. So the topic of conversation today is all about medical interventions. And so, Robyn, I'm going to hand it over to you to get started on this interesting topic.
Yes, it's a very highly active topic at the moment. Well, it has been for a long time, but even more so at the moment, where we are having a lot from the women that we are talking with around the world. We are having a lot of information coming in video form, in written form, in data that's recorded in a database about the way women are being treated. And when the midwives, like me, the old girls, hear
I'm not answering
what those women are saying, that's really heartbreaking, because I have come through an era where this didn't happen to women. And they're talking about abuse, very questionable interventions, and also about induction of labour, being told they have to have an induction of labour or coerced into an induction of labour before they've even, got halfway through their pregnancy. There's somebody else's plan to, induce the labour. And we do know that induction of labour ends up in a cascade of intervention. We do know that the caesarean section rate, by all the data, is increased by inducing the labour. And when you think about it, it makes sense, because you're changing the hydraulic pressure that the baby in the uterus need to be able to progress through labour. So we're constantly doing things with and to women that are very questionable. And in my circumstances, the way I speak with women, I would believe some of it's unnecessary, because the women are talking about how they feel abused. They're using that language. It's not my language, it's their language. The abuse is quite frightening. Then what happens is they lose the focus of their ability to use their innate knowledge, their own instinct, the way that they go about their business in labour and birth. And one example I can give is that when, in my experience of many years, women, particularly with their first time labours, had an innate period of time where they've laboured hard for a reasonable long period of time, and then they get tired. But their labour doesn't stop, but we nest them and they quieten down, and they have a nice rest period. And once they wake up, 4 to 5 hours later, some of them, they are on their way like you wouldn't believe, and they're giving birth within a very short space of time. So we replace that innate period with opiates, with epidurals, with opiates from epidurals. We replace that from restricting women to beds, fetal monitors around their abdomen. We do a whole lot of things that introduce drugs and technology that is very questionable for a woman who's actually working well in her labour, with the desire to accelerate her labour. Rachel.
And the flow on from that is what we're often seeing is that women are coming back to us reporting that they actually got signs of post-traumatic stress.
Yes.
And we see that from war soldiers, and it's not okay that women are coming from a normal, healthy event such as giving birth, pregnancy and giving birth, to having post-traumatic stress syndrome.
Yeah, and having a midwife by your side who's there for you, with you, and she's there hearing, seeing, sensing, feeling what you are doing, how you are progressing, and she knows what to do. Instead of that, the midwives are running in and out. The students are absolutely bewildered because, you know, everything is just overwhelming for all of them. They become victims of the system rather than giving birth to their baby. Sarah.
And the midwives find it hard, don't they? Because they're dominated by medicine, and now they've got such regimented controls on what they're allowed and not allowed to do. They can't actually be with woman, and the woman actually is really not even in that picture. What she wants or thinks or feels is often void.
I think it's sort of an era of obstetric nurses and not midwives anymore. We've got this obstetric nursing and the technology nurse rather than the beside woman.
The hands-on.
Yeah. So what would you say, Sarah?
Well, I think we can all agree that a lot of women go into hospital to give birth to their babies and they have not prepared for any unforeseen circumstances or are quite unaware of any of the interventions that may be put forward to them. And I think at least having a little bit of understanding or some preparation into what may happen goes a long way in being able to make the right decision.
And how to deal with it.
That's right.
Confidence
and
to say no.
Knowing what your rights are,
Yeah, definitely.
Yeah, it's a difficult time for a lot of people, and that's where I developed the education program that I have on the Isation syndrome. The Isation syndrome is sort of what was all in my head is now put into an education program with some models to show what was happening over the experience that I've had, seeing the changes over that time happening, and how we are really women who no longer can give birth to our babies. We're women where our babies are extracted or they're delivered by someone, and the giving birth process is being set aside.
Definitely, and I really noticed the dynamic shift going into hospital to give birth, especially from a nurse's point of view, that as soon as you go through those doors, you become the patient, not a woman giving birth, and it really knocks the confidence out of you a little bit.
I was just speaking with a mother about half an hour ago. I've been talking with her for quite a while, and this is her fourth baby, and my goodness, the way she expresses in her language and her storytelling about how she was treated previously. This time she's trying to avoid that, but it's very, very hard because they're telling her she doesn't have any say. Well, of course, with consent, the law of consent, they do have say. So you're right, Sarah, having knowledge before you go is really, really important. Yeah. And then the mother just yesterday, I think it was, who was told that while she was in hospital, that baby wasn't hers. She said, no. She said, no, you can't take my baby. And she said, yes, we can, said the midwife. While you're here, the baby belongs to us.
I've heard that before too. That's disgraceful.
I've personally experienced that. Yes.
Oh, I didn't know that. Well, you see, that was just yesterday, so it's been ongoing, obviously. The baby does not belong to anybody but the mother and the partner.
That's right.
Goodness me, how they can even use that language is inappropriate.
Completely inappropriate.
Yeah.
And then I guess we see the follow-on from that, don't we, Robyn and Sarah, is the breastfeeding problems that come with medicalised birth.
Yes. And the lack of acknowledgement that it's so important for that little baby to be with its mother, not to be handled by others with an APGAR of 7 APGAR score. This is where women need to learn the APGAR score as well, and their partners. With an APGAR score of 7 or more, that baby does not need to be handled by anybody else. It should be directly with the mother regardless of how the birth takes place. Regardless, that is with the mother. So no other mother, mammal and baby, except at the zoo maybe, is treated that way. No other mammal is taken from the mother in the way that it happens at the moment.
And when I think about that, I used to have those little piggies at home that used to have their babies. And you know what? It's just really magic watching them. And really, they're really instinctive. Like, you know, you can sit very quietly and watch them. So they love me. So I was allowed in their space quite comfortably without disturbing them.
What were they? I missed that.
My pigs, my little pigs who were having their babies. And watching, you know, they're so amazing. And they, you know, they nest. And they go quiet, and they'll just labour, and then they have their little babies. And when they're ready, they come to, and they just make their way around to the other, and they'll just feed. Like, they don't need any help. Like, it's just magic watching them. And humans can do that safely. Most of the time, there are certain times, you know, obviously some people do need help.
And Sarah, you work in mental health as well, so you've got an even broader experience of, you know, the effect on people when we take away their
rights. Absolutely. And I thought, considering I went in very prepared to hospital to give birth, I thought my birth overall went quite well, but I fought for it as well. That I did not anticipate the processing that went on afterwards, where you sit and you think and you go over things and you feel frustrated and you feel let down by the system and you wish you could have spoken up. So I really can't imagine how some women feel when they've really been, I suppose, potentially taken advantage of by the system and their policies.
Yeah, we can't feel what they feel, but we can hear what they say.
That's right.
And that's the advantage for people like us, because the women are coming to speak with us, and that's what we hear. We hear so
we can hear the hurt.
Yeah, that's right. Yeah.
It's a grieving process, actually, isn't it?
So I suppose what's the question? How do we go about effective change in not agreeing to things that are unnecessary? So I suppose for me, the first step would be for all women in whichever country they come from to explore the law of consent and make sure that if everybody follows the law of consent, then they cannot touch them without their consent. They cannot do things to them. So I think that would be one way of it, but we need to explore those things. And there is a group started up now, Transforming Midwifery. Is that the title of the group? And
I've not seen it, Rob.
Yes, Marie, have you got it handy for me? Transforming Midwifery is Professor Jenny Gamble. What's
Transforming Maternity?
Transforming Maternity. Thank you.
Okay.
It's new, and I think a lot of us should be sort of following and supporting and that, because I think they're on a track where things will become much more understandable, especially with all their experience and ability with the data and the research as well. It's a big team of people that are actually coming together. So,
and I think for me, part of that is having the woman at the centre of her care, with her known midwife who encompasses her, looks after her, guides her care, and if she needs any other professional, she's coordinating that with that woman with her consent. That's important. And orchestrating that so it happens. But every woman, regardless of risk, should have one midwife through that whole journey with her until about 6 weeks postnatally, so she has that one point of contact.
And
so
we do know that, you know, things happen in the moment, and none of us, whatever profession we're in, can give 100% guarantee to anybody, but we do go about our practice not causing harm. So we don't go out with intent to cause harm. And so what happens then is if things do need help, then we are complementary with each other. We're not
exactly
in competition with each other.
We're not working in silos. We are actually interacting.
And the women are always included, I believe, should be included. And many, many times they're not. Decisions are made over and above them. And
absolutely,
we are not practicing in a fair and reasonable and accountable way.
If you are just popping in, you'll hear that Dr. Robyn and Rachel Austin are discussing the increase in medical interventions. Now stay tuned, because soon Dr. Robyn will discuss and talk all about cervical dilation during labour. Give us some love, a thumbs up, and don't forget to hit that bell.
Yeah. So we've just had a comment come in from Shari, who says she was forced into internals, I'm assuming vaginal examinations, while giving birth 2 weeks ago, despite saying that she has a history of abuse and not wanting them.
That's one of the major complications, and that's in my video, Keep Your Fingers Out of My Vagina, Please. And
that's a good video. I like that video.
That includes that fact that, you know, many women have suffered abuse, sexual abuse, domestic violence, and that's not taken into consideration because maybe the people don't know about it because she's not able to speak about it. But if the midwife with woman, like you said, Rachel, every woman is entitled to a midwife who is beside her on her journey for as long as it's possible, from pregnancy right through to 6 weeks postnatal. That's what they're entitled to. If we really care about the women and their well-being, for looking after their families, future generations. They work 24 hours a day, 7 days a week, unpaid, with new babies, little toddlers and children, and they are providing future generations for this country and for other countries, and we need to respect that. And when we hear that, you know, like Shari says, Shari, we're really sorry. I'm sad I wasn't there with you. Because it wouldn't happen on my show.
Or hell would have broken loose if Robyn was there.
If I knew you well and I knew your history, then that would not happen. So I'm really sorry. And in the fact that you actually said it to them, that's even worse, that they've invaded your body. They have no right to do that. So
Shari, maybe at some point you may, when you feel strong enough, is actually write your story down.
Yes.
Maybe share that with the hospital and the staff, and maybe they can reflect on their own practice.
And publish it too, Shari. Publish it, because it's the only way that more and more information will be.
Is that your toddler?
That's my child.
That's all right. He's gone. Don't worry about it.
See, we're all working mums, aren't we?
Oh, so Shari's... she's clearly dealing with a newborn and 2 toddlers because she can't type.
And Sarah's kid is banging in the background. And
don't worry.
Is ringing me.
It's beautiful.
See, this is how it just works.
This is real life, though, isn't it? It's real life. So we want, from my point of view, before I leave Mother Earth, is about education, not training. Education, training on rubber dolls doesn't do anything for me, because the rubber dolls don't respond in any sensitive way at all. It's about education. It's about being beside the younger midwives, supporting them, nurturing them, guiding them through difficult situations, how they learn, all the things, the valuable things that I had access to and was able to learn, that gave me years and years of good experience. So I figure that we are letting our student midwives down, we are letting the young graduate midwives down, and because we are conforming to a system that is using us as their database collectors, as their pushing women through the system, accelerating the process all of the time, and we need to stop. We need to say stop. Our duty of care is with this mother and her baby when it arrives, or with her and her baby. This is our duty of care right now. So if you have a problem, please go to management. Please don't push the problems onto us.
And Shari, I can just see that you've made a comment there as well, and it may be really helpful for you to have, see a psychologist and talk about that. And maybe someone who actually does specialise in birth as well, or even a midwife, if you can get a midwife and sit with a midwife.
Yeah, Shari, for many years I have been with women who I have either, it's a decision that we make before we start, and whatever that woman wants, but we either record her story as she speaks it, and her and I are together. I write it while she speaks it, or she can record it nowadays on her phone as well if she wants. And then she reads that story. There'll be many, many tears. And then she decides if she wants to expand on it and write her story. If she's able to, I would suggest publishing it somewhere if she can. But that depends on how she feels, dates, times, place. Of course, getting someone with that sort of written experience, maybe reading it to see if you've measured up all the disclaimers that you have to do for various things. But I do think if you can either speak it through the lips or you can write it through your fingertips, it releases the pressure in here that's continuously turning like a merry-go-round. And if you can do that, it does help. You might need little breaks. You may not write it all at once. You might write it over a couple of years. There's no time factor to it. There's absolutely no rules whatsoever, but it does help, genuinely help, if you can do that. Yeah. So
it's about processing, isn't it?
Yeah, it is. And yes, you might like a psychologist or someone to speak with to help you along that way too. But, everybody's unique.
Everybody's different.
Yes. So it's very important that you listen to the way your instincts are guiding you, because we talk about always uniqueness of every woman and every baby, every family, and uniqueness and instinct as well.
You take care, Shari.
Yes, we're feeling for you, Shari. So, and if the tears flow, let them come.
Let them come,
Let them come, So, is there this?
So, okay, well, is there anything else that you would like to add before we finish off?
Well, can I just talk about, and you guys might like to support me here with the one intervention really worries me, and that's the induction of labour with a balloon. If you look at the anatomy and you think about how the cervix dilates, it doesn't dilate from a balloon being pushed into it this way and expanding it, and it does not. That's not how the cervix fibres are meant to dilate. It comes down with the pressure of the water and the baby's head, which then effaces the cervix, and as it does, it's starting to move out, and when it moves out, the canal down here, the orifice at the top and the one at the bottom, the sphincters at the top, open, and then simultaneously, if it's a second, third, fourth baby, often quicker, but for the first baby, it takes time to efface and begin to dilate. And one of my horrid experiences was at a major hospital where a mother was crawling around, a young mother was crawling around on her hands and knees, screaming, asking them to take it out. And the midwife came in and said she can't, she's not allowed to. The husband went to the desk and asked for it to be removed, and they said they can't. So they chuffed her off to the labour ward instead, and of course all the intervention took place. So that really worries me, that we are inserting things into the body that should be really reviewed. The latest is returning the 50 years ago they used to do this when I was a young midwife, and now I'm an old midwife. And they used to put a digit in the anus to feel what was going on, and to feel if it wasn't necessary for a tear then, but to feel the baby's head as well, but to feel for tears. Now it's been returned. And I would say to you quite strongly as a mother to say, no, you cannot put your digit in my anus. What other mammal puts up with that? What other person puts up with that? If they want to have a good look at a tear that is beyond what they feel capable of suturing, then they need to do that with a light anaesthetic.
Yeah.
They need to be respectful and stop doing those things where they're invading women's bodies again after all of those years. It's wrong. That's my take on it, and I'm sure there'll be plenty of others who disagree with that, but that's fine. If we don't speak out when we can and with our knowledge, then we're not doing the right thing as being responsible professionals as well.
I 100% agree, Robyn. I couldn't think of anything worse after having a baby than somebody violating your body like that.
Yeah. So we need to improve the education regarding tears, and we have to try very hard to stop coaching people to push women to push, because what we do then is we are not working with her rhythm and her body and her mind, because that's all internalized. We are just working with what we think should happen. So by encouraging pushing can make that perineal muscle tear much worse, much quicker.
Absolutely.
It dilates and it stretches and it moves with the baby coming down just a little bit at a time. It moves in 8 different directions. So if the woman finds her comfortable position wherever she wants to be at any one point in time, she can change her position 100 times. But the worst thing she can do is to be flat on her back. And flat on her back after an epidural is even worse again, because she just hasn't got the ability to sense it all. So working with a woman side by side in her rhythm, quietly, gently, and working with her for the time it takes for her to progress her labour and give birth to her baby. We should not walk away. We should not transfer her to hospital because we've reached 8 hours. That's the wrong thing to do.
Yeah.
Have a buddy system where you have a midwife who backs you, looks after you while you have a break, and then you help. There's so many things that I want to see happen again before I depart. Yeah,
and that's it. There shouldn't be a magic time or a magic number on a labour, should there, Rob? It should be individual.
It's about, the key word is progress, and the progress is unique, and it depends on that unique mother, her body, her baby, her history, her situation, anything that's happened to her in her pregnancy or before. All of that is relative.
Well, I think we better start opening some Thompson Method birthing centres.
Absolutely. Are you up to being back on call again, Rob?
Well, we had some beautiful birth centres and they were all closed down. Closed down by the politicians who moved everybody into large public hospitals, and that was in my time too.
And that's what they're doing with the rural hospitals at the moment. We started the task force to review rural, and then they've pushed that aside now, and they've stopped it.
And these are the consequences. Women,
the consequences
being accelerated through a hospital system because we've interfered with what women would do in a birth centre or in a birthing home.
Well, the rural mums are giving birth on the side of the road because they're travelling often many hours in labour because they can't leave their properties often to get to major centres, or they can't afford to.
No, it's there is a definite lack of respect for women. Absolutely a lack of respect for women. So hearing my passion and hearing my team working with the same passion is how we see ourselves working for as long as we possibly can. And we are here for the women and for their babies. We are also here to be complementary with our colleagues when it's necessary, when their skills are required. It's beyond our skills. We're here for that too. And but we're at a point in midwifery history where this is not good enough with what's happening with women and their babies and their families. Yeah.
Absolutely.
Yeah.
Well, thank you, Robyn, Rachel, and Sarah for sharing your expertise and highly experienced opinions as well, because they're more than just opinions, really, aren't they? They're steeped in knowledge and experience over a long period of time. Yeah. So it's so good to be sharing this information.
And nurturing the youngest students and those that are coming through. Let's nurture them and guide them and help them through the times that they're heading to that we've already been through for a long time. Yeah.
Absolutely.
Yeah.
Love it. All right, ladies. Well, thank you. And we're going to be back online
You're beautiful,
again.
Shari. Thank you, everybody. I'm just reading all the comments come through.
Oh, yeah. Thanks, Shari. That's lovely. We're going to be live again tomorrow morning, and again, and then this time tomorrow night, Chelsea is going to be interviewing you and Rachel and Sarah and Kelly. If you guys want to hop on as well, it's always the more the merrier.
That would be fun.
Anyway, to
So
all the wonderful women out there, stay strong and if something you stand with what you think is right for you in your instinctive way. That is very, very important.
And I guess the other thing is we have the Healthy Mother, Healthy Baby group as well. So if you are pregnant, jump on there.
Yeah, okay.
Absolutely.
Yeah.
Hop onto the website, ThompsonMethod.com, and you can see all the programs that we have available. And of course, we are 50% off the breastfeeding program, which is an amazing online education program and support in the breastfeeding club as well. So thanks for joining us, ladies, and we'll catch you soon.
Thank you.
Thank you.
Bye.
Bye.
If you've enjoyed this video and you haven't already joined our free Facebook group, we're going to pop the link down below for you guys to click and join. And this will be accompanied with the link, the downloadable link, which I mentioned during the video, which is Dr. Robyn's guide towards pain-free breastfeeding. Give us a thumbs up, hit that bell so you don't miss out. And remember, it's your body, your baby, and your journey. My name is Chelsea Curley, and I will see you soon.